Well, my name is Jason Schillerstrom. I'm an assistant professor of psychiatry at the University of Texas Health Science Center at San Antonio. I did my medical school here in San Antonio, and then residency in psychiatry afterwards. I've done an additional year of geriatric psychiatry fellowship training after that, and eventually I graduated and am now on faculty at the medical school here in San Antonio. I joined the faculty in July of 2005. My major jobs are research. I generally look at the interface between medical illness and cognitive impairments. I have an outpatient geriatric psychiatry clinic at the medical school, and then a lot of teaching medical students and residents as well. So this morning we're going to talk about dementia, and we're going to try and understand what is dementia. And so first we're going to describe the diagnostic criteria for dementia, and then after that we'll talk about different types of dementia and how different types are similar and how the different types are in fact different from each other. We'll speak a little bit about, very little bit about the biological changes associated with dementia, and then we'll touch a little bit on prevention and treatment. So this morning we're going to answer the question, what is dementia? And so the first criteria for dementia is that you have to have memory impairment. And so there's lots of different types of memory. There's long-term memory, short-term memory. There's verbal memory. There's motor memory. So verbal memory might be, for example, people's abilities to remember names and recall recent events. There's memory tasks, such as we'll give people some words to remember, and then we'll distract them with a task, and then we'll go back to the task and ask them what were those words we asked them to remember. Examples of motor memory would be things like, or procedural memory might be things like riding a bicycle, for example. You're even if you haven't ridden a bicycle in years and years and years, chances are you still remember how to do it. When you hop on the bike, you could still go. So to have dementia, you have to have memory impairment. And even if you don't yet have true impairment, having, and for some dementia types, having decreased memory functioning relative to your previous level of memory functioning could still meet criteria for this sub-criterion. So you don't necessarily have to be severely impaired. Your memory, even though it may essentially be good, if it's worse than it had been, that can still count. So the first criteria is memory impairment. The second criteria to be diagnosed with dementia is you have to have one of these following technical terms. So you have to have aphasia, or apraxia, or agnosia, or executive function impairment. And so we can talk about what each of these are and how we test them. And so aphasia is aphasia is a loss of can be thought of as a loss of verbal skills despite having intact verbal mental hardware. So people struggle to speak. It's a speech impairment. And there's different types of aphasia. Most commonly what we'll see is what are called expressive aphasias, which is what I'm doing right now. I'm struggling to get the right words out. And so expressive aphasia might be, examples of an expressive aphasia are, we might show a patient a pen, for example, and we might say, what is this? And the person would, you might say, well, that's a pen. But the person with dementia might say, oh, it's one of those things that you write with. It's like a It's a writing instrument. And it's on the tip of my tongue. I just can't get it. They can't get out pen. Or we might say, what is this right here? And they might say, it's a clock. Well, it's not really a clock. It's like a clock. You tell time. And they can't ever get the word watch out. And so we'll ask our patients with dementia to identify different objects to see if we can elicit the aphasias. Another common example where we'll elicit aphasias is to ask them to repeat kind of tricky phrases. And so the one we use most commonly is probably repeat what I say, no ifs, ands, or buts. And the reason we specifically use no ifs, ands, or buts is because ifs, ands, and buts are not commonly thought of as nouns. So we're now using these words that are not, they're usually transitional words. They're not nouns. And so people who have these aphasias, they'll struggle to use these words in this different context. And we'll get answers like no ifs, no ands, or buts, or no if and but, and they'll just struggle to get the words out. No ifs, ands, or buts. So they're struggling to speak. It's a speech problem, but they're not struggling to speak because because the muscles in their larynx don't work, or because their tongue doesn't work, or because the pathways going to their musculature don't work. They still have intact speech hardware. They just can't get the right words out. So that would be an example of aphasia. For apraxia is where a person has impaired motor abilities despite having intact motor hardware. So similar to aphasia is a disorder of speech. Apraxia is a disorder of motor abilities. And so examples where we will test people's motor abilities is we might say, I want you to take this piece of paper in your left hand, I want you to fold it in half, and I want you to put it on the floor. And they'll take it, but they might take it with both hands or the wrong hand, and they'll kind of struggle to fold it in half, and it kind of turns into this mess, and then they might drop it on the floor eventually. But they're just not able to manipulate the object like they once were. Other examples where we'll try and elicit apraxia might be, we might ask our patient to show us, I want you to pretend you have a comb in your hand and show me how you would comb your hair. And so someone with apraxia might take their fingers and they might kind of do something like this, where they're showing you how they would comb their hair. But that's not how you would use a comb, right? The way you would use a comb is you would pretend to hold a comb, and you would, in fact, comb your hair like this, right? And so, again, that's an example of apraxia. Agnosia is a person's agnosia is similar to apraxia. Apraxia is a loss of motor functioning. Aphasia is a loss of speech functioning. Agnosia is a loss of sensory functioning. So a person loses their sensory abilities despite having, again, intact sensory hardware. So examples of how we might elicit agnosia would be, we might have a person close their eyes, and we might put a paper clip or something in their hands, and we would say, tell us what this is. And they would struggle to identify, in this case, the paper clip. Commonly we'll use paper clips or coins, that kind of thing. And it's not that they can't feel it. They can. So the question isn't, can you feel this? It's not a matter of feeling. It's what is it? Can you identify what this is? Okay? And so that would be an example of agnosia. And then the last is executive function impairment. And so executive function impairment is perhaps the most critical cognitive loss that there could be. And so executive function impairment is your ability to plan, organize, sequence, monitor, and inhibit complex goal-directed behaviors. And so the way that there's different ways to conceptualize this. A synonym might be it's your problem-solving abilities. It's can you solve problems when presented with unique circumstances. And so in a way, it might be you might think of it as problem-solving abilities. Other people might think of it as it's kind of related to judgment or insight. And so regardless, it's all of that. It's your frontal lobe functioning is what it is. And so the way that with my medical students, the way I'll explain executive function is that it's your ability. It's the set of cognitive processes that allows you to behave independently from your environment, instead of having the environment mediate your behaviors. And so you don't want the environment to control how you behave. And so we can think of different examples of executive function impairment in elders. And so driving is probably a great example. And so you can imagine with driving, there's you have to plan, organize, sequence. You can just think of all the cognitive abilities it takes to, for example, drive a car. And what will happen when people become executively impaired is they become dependent on habit, and they become dependent on routine. And all of a sudden, their environment will start to control their behaviors. And so we can think of driving as an example, such that you'll hear on the news, for example, that someone was intoxicated with alcohol and they hit a pole, or they're intoxicated with alcohol. And you'll hear about police officers who've pulled someone else over and the police officer's car gets hit. Or they hit a tree, they hit some object. And what happens, again, when people become intoxicated with alcohol is that they become executively impaired. Their frontal lobe ceases to work, and they become attracted to whatever the strongest signals are in their environment. And so you can imagine if a police officer has pulled a person over and the lights are flashing and the blinkers are blinking and there's this big scene, then that scene becomes the strongest stimulus in the field. And then if someone's intoxicated coming up, they'll just drive right into that stimulus. Similarly, there'll be stretches of highway out in West Texas where there is no trees for miles, and yet someone will become intoxicated and hit that tree. And you'll say, man, what are the odds of someone hitting that one tree, right? And what happens, though, is that people become attracted to the strongest stimulus in the field. In this case, it's a tree, and the tree is just calling to them, and they just hit the tree. And so that's an example of how when people become executively impaired, their environment is mediating their behaviors. Similarly, in nursing homes, a big challenge would be wandering behaviors. And so we can use a nursing home example of doors with doorknobs. And so what will happen is people will walk up to the door, and there's a doorknob, and the doorknob is just calling them, saying, turn me. And so they just turn the doorknob, and they walk through the door. And again, they're just defaulting to their habits, and the environment is dictating their behaviors. Cooking might be another example where you can imagine that if someone is in their kitchen and they're cooking a dish that they've always cooked before, as long as there's no interruptions, then things usually go fine. Every single time, things will always go fine. However, in executively impaired people, if there's an interruption, if the routine is broken, and the person has to step away, for example, maybe the phone rings and they step away and then they come back. It's not that they've forgotten how to make the recipe. They just can't reset, reorganize. They don't have the ability to monitor what they've been doing, and that's when disasters happen. That's when accidents happen in the kitchen. So these are examples of executive impairment, executive function impairment. Again, you can kind of think of it as problem-solving type abilities. And so, again, to be demented, you have to have memory impairment, and then you have to have one of these other four cognitive losses, either aphasia, apraxia, agnosia, or executive function impairment. And then finally, you have to have functional impairments, functional decline. And so functional decline is just that. It's you are no longer able to do the things that you used to do. You're no longer able to meet your self-care activities, your self-care needs. And so these are things like higher order examples of functional decline might be things like using the telephone, managing your money, managing your medications, driving or arranging for transportation. Those would be higher order levels of functional loss. And then more basic functional loss would be things like walking, toileting, grooming, showering, these kinds of things. And so, in general, when we think about functional loss is what ultimately predicts the level of care that people need. And so when people lose their higher order functional abilities, and these are things like telephone, their ability to use a telephone, manage their money, manage their medications, arrange for transportation, housekeeping, when they lose higher order functional abilities, then what they need is an assisted living level of care. That's when people will need an assisted living level of care. When they lose the basics, their ability to groom themselves, bathe, shower, ambulate safely, and toileting, then that's when they need a nursing home level of care. And so what predicts the level of care isn't so much cognitive loss, it's functional loss. Okay? And so this is the textbook definition of dementia. There are different dementia types. One of the challenges that we have is, in my clinic, people will come and they'll say, I'll tell them that, this is dementia. We'll run through the tests and we'll say, in fact, this is dementia. And they'll say, oh, thank goodness it's dementia. We were worried it might be Alzheimer's disease. Or it'll be the opposite. In my Hispanic population, it's the opposite. It's, oh, thank goodness this is Alzheimer's disease. I was worried I was demented. And so it kind of depends on cultural backgrounds. And so what's important to know is that dementia is the broad diagnostic category. And then there's different types of dementia. And so one type of dementia is Alzheimer's disease. But there are other types as well. And these other types just don't have the press that Alzheimer's disease has. But there are other important types. So there's Alzheimer's disease, vascular dementia, and Lewy body dementia. So Alzheimer's disease, vascular dementia, and Lewy body dementia, these are the three most common types of dementia that I see in my clinic. There's lots of other types out there. So for example, there's frontotemporal dementia, there's dementia secondary to metabolic changes, there's dementia secondary to chronic alcohol or substance use, Pick's disease, Creutzfeldt-Jakob. There's lots of different types of dementia out there. But the three that I most commonly see are Alzheimer's disease, vascular dementia, and Lewy body dementia. And so each of these has a different either neuropsychological pattern of loss or other important comorbidities as well. And so we can talk a little bit about each of these. And so with Alzheimer's disease, without a doubt, the hallmark feature of Alzheimer's disease is memory loss. Without a doubt, it's memory loss. And so there's different parts of the brain that encode memory and that store memory. And so with Alzheimer's disease, the characteristic pattern of Alzheimer's disease is people will have non-promptable memory loss. Their memories don't respond to prompting. So for example, what we might do is we might say, okay, I want you to remember 3 words. I always do apricot, table, and penny. Those are my 3 words. Okay, so I say, I want you to remember 3 words, apricot, table, and penny. And then we'll distract them with another task, and then we'll go back, and we'll say, okay, what were those 3 words? And a person with Alzheimer's disease, they won't remember the words. They're not able, their brains aren't able to encode the words. And so then I'll say, okay, well, it seems like you're struggling to remember the words. Let me give you a hint. One of them was a fruit, and they still don't get it. And I'll say, okay, well, was it an apricot, a banana, or a cherry? And then they're just truly guessing. And so people with Alzheimer's disease, not only do they have memory impairments, but their memory impairments are non-promptable. They don't respond to cues, okay? That's kind of the hallmark feature of Alzheimer's disease. They don't, early on, that's what we'll see, is they have these non-promptable memory deficits. And so with Alzheimer's disease, let's see if I can shift this up. What's happening in the brain is, and again, I don't want to talk a lot about the biology, but nonetheless, I do think there's some important words to know. And so there's different pathological changes that are happening in the brain. Right here, we have the temporal lobe would be in this area right here on the side, and then right up front is of course, the frontal lobe. And so buried in the temporal lobe is a structure called the hippocampus. And the hippocampus is where memories are encoded. And so within the hippocampus, or what starts out near the hippocampus and then spreads into the frontal lobe, are these pathological changes that are called tangles and plaques. And so in a typical nerve cell, if you look at a nerve cell under the microscope, you'd be able to see a nucleus right here, which is the center of the nerve cell, and then you'd see clear cytoplasm surrounding the nucleus. In patients with Alzheimer's disease, there's a protein called tau, and the whole cell just darkens out. And so you'll see these tangles where you have these intracellular protein accumulations, and the whole cell just darkens out and it dies. And so that's what a tangle is. For plaques, there's different proteins that nerve cells secrete, and so one of the proteins that they secrete is what's called and it's an amyloid protein. It's a amyloid precursor protein, which then gets spliced up into different ways. And sometimes when this protein gets cut, it's healthy, and and the product is neuroprotective. But sometimes when this protein gets cut, this amyloid protein gets cut, it doesn't fold correctly. It becomes really sticky, and you'll get these extracellular accumulations called plaques or amyloid plaques. And so if you look at brains under the microscope, it's just filled with this amyloid plaque. And so you'll get all these little plaques all in the brain. And then you get all these tangles, and the whole front part of the brain and the temporal lobe of the brain just fill up with plaques and tangles. And these plaques and tangles are neurotoxic. They kill nerve cells, and that's where the cognitive loss comes from. That's where the memory loss comes from. It's coming from these pathological brain changes. Okay? So that's Alzheimer's disease. Another type of dementia is vascular dementia. And so what will happen in vascular dementia is people will have little, typically what we'll see is people will have small, tiny strokes in the front parts of their brain. And these little strokes, people might not even know that they're having them. It's not your classic stroke where, half of your body goes numb and you lose motor functioning, where you clearly know you're having a stroke. A lot of times in vascular dementia, people, the strokes are so small, they don't even know they're happening. But they happen, after a while they accumulate, and these vascular lesions impair cognition. And so most commonly what we see is that. We see an accumulation of small, tiny strokes in the front parts of the brain, and people start to lose their cognitive abilities. Of course, we also see dementia from the large classic strokes as well. And so these large classic strokes where people do lose, motor control on half the side of their body, and they do lose sensory functioning on half the side of their body. Of course, those can lead to dementia as well. More commonly, it's these small ones that we'll see. And so with vascular dementia, the risk factors, as you might imagine, are all the risk factors for vascular disease. So it's things like smoking, high blood pressure, high cholesterol, not exercising. It's all of the classic. Anything that can give you vascular disease in your heart can also give you vascular disease in your brain. And so when we talk about how to protect your brain, what can you do to protect your brain? My goodness, it's not smoking, it's exercising, it's getting your hypertension and your high cholesterol under control. And so with vascular dementia, their memory impairments are a little bit different. What we'll see with vascular dementia is while they do have memory impairments, they have promptable memory impairments. And so for vascular dementia, I might give a person 3 words to remember, apricot, table, and penny, and then we'll distract them, and then I might go back to them, and they might not remember any of the 3 words. But then in my vascular dementia patients, I'll say, okay, one of them was a fruit. And they'll say, oh, doc, that was the apricot. And they just remember. Okay, well, one of them was a coin. I think it was a penny. Okay? And so while they have memory impairments, they have promptable memory impairments. And so that's kind of one of the ways we start to differentiate between vascular dementia and Alzheimer's disease, is based on do they have promptable memory loss or do they have non-promptable memory loss. The other thing that we'll see with vascular dementia is this classic stair-step down pattern. And so with Alzheimer's disease, if you look at, so if this is time and this is cognition or memory, in Alzheimer's disease, what we'll see is just a steady decline downwards. Okay? That would be Alzheimer's disease. In vascular dementia, what we'll see is someone will be at a current level, and then they'll have a stroke, and they drop down. And then they're at that level for a while, and they're doing okay, and then they have another stroke, and they step down. And so it's more of a stair-step pattern down. It's not this continuous gradual decline. It's this they just kind of stair-step down, and every time they have another stroke, they take a cognitive loss, and then they're at that level for a given amount of time, and they might have another stroke, and then it's another loss. And so they stair-step down, as opposed to Alzheimer's disease, which is generally this unrelenting slope downwards. And so what's nice, in a way, about vascular dementia is that if you can control for the vascular risk factors, vascular disease risk factors, you're not necessarily declining. And so it's quite possible that a person might have a stroke, and then they get their hypertension and their high cholesterol under control, and they stop smoking, and then they may not step down ever again. They could just keep going along at that certain level. And so it's not this unrelenting decline downward. The last type of dementia that I'd like to talk about is called Lewy body dementia. And so this seems to be it seems to be more and more prevalent in our society. And some say it's now the second most common type of dementia. Alzheimer's disease is the most common type. It's typically been thought that vascular dementia was the second most common type. But Lewy body dementia seems to be on the rise. And so Up to a quarter of all dementia cases now might, in fact, be Lewy body dementia. And so with Lewy body dementia, you still have the same memory impairments, aphasia, apraxia, agnosia, but you also have other symptoms as well. And if you have two, you have to have 2 out of 3 of these symptoms. And so the first would be, we'll say, visual hallucinations. And then the second is Parkinsonism. And then the third is, I'm going to put, it's fluctuations of consciousness. Okay. And so with the visual hallucinations, what will happen for people with Lewy body is they will see fully formed, detailed images that aren't there. And commonly it's like children or animals like cats, or it'll be like little figurine people, or it can be anything. But what's important to know about the visual hallucinations is that they are as clear as day. So it's not, sometimes in schizophrenia or bipolar disorder, or sometimes in other mental illnesses, they might say, I see things out of the corners of my eyes. I see shadows or something kind of vague. In Lewy body dementia, they see a person standing right in front of them. They see them there. And so this can be frightening. On the other hand, a lot of times the visual hallucinations aren't frightening. They're very benign. And so, we'll ask people, do your eyes ever play tricks on you? Well, no, I don't think so. Okay, so you never see like cats or dogs or anything like that. And they say, oh, well, you mean that cat right there? And there's no cat there. Or what they might do is they might, they'll go to the kitchen and they'll get some, they'll bring out 3 Cokes, and they'll bring a Coke for themselves, a Coke for their wife, and a Coke for this nice little girl that's sitting right down on the floor by them. And it's just as clear as day. What's interesting about the visual hallucinations is that, at least in my clinical experience, what I see is that they don't talk. They don't have auditory hallucinations. So you won't see them necessarily having conversations with the hallucination. And so it's purely visual. It's not auditory. In schizophrenia, for example, the problem with schizophrenia is the auditory hallucinations, right? They hear voices that aren't there. They don't necessarily see things that aren't there, although they very well could. So that's visual hallucinations. For Parkinsonism, Parkinsonism is like Parkinson's disease. A lot of times in our Lewy body patients, we might not see kind of the classic pill rolling hand tremors. Usually the Parkinsonism is more subtle. So for example, they might have what's called cogwheeling, where if you move their arms up and down, you kind of get this ratcheting effect. So they have this motor stiffness, and their gait is very Parkinsonistic. They kind of shuffle along. They'll have the kind of masked faces, or kind of this poker face where they kind of lose their facial expressions, and they're just very, again, just without any affect in their facial expressions. So that would be Parkinsonism. And then finally, it would be fluctuations of consciousness. And so for fluctuations, a lot of times, for my patients, what I'll do, or for the caregivers of my patients, is I'll ask the caregiver, does your loved one ever have spells? And there's kind of 2 answers that I'll get. I'll get, well, what do you mean by spells? And if I have to explain what a spell is, then the answer is no. And so, however, for a lot of them, they'll say, oh, yeah, they do have spells. And so then I'll ask the question, well, what do you mean by a spell? And then the answers just vary widely. And so it can be anything from kind of the classic sundowning picture where the person is essentially fine during daylight hours, and then around 3 or 4 in the afternoon, maybe a little later, they become more confused and more disoriented. Their personality just changes. It might be that they have spells from week to week and not every day, but in some way they have their consciousness it fluctuates in some way. And so this without a doubt is the loosest of the three criteria. It's the one that's hardest to get at. But nonetheless, if a person has 2 out of 3 of these criteria, then they would meet criteria for Lewy body dementia. And then if you compare this to these clinical criteria to pathology, where you're actually looking at the brain slices after the person has deceased, having 2 out of 3 of these criteria, it's about 80% sensitive and specific to pathology, which is a really big number for simple criteria like this. So that would be Lewy body dementia. I don't want to talk a lot about therapies and treatments, but we will go ahead and talk a little bit about them. And so right now, in general, there's 2 different medication classes that are FDA approved for Alzheimer's disease. They're for Alzheimer's disease. And so the first class of medicines are acetylcholinesterase inhibitors. And so these are medications like donepezil, which is marketed as Aricept, rivastigmine, which is marketed as Exelon, and galantamine, which is marketed as Razidine. And so you've probably seen these medications advertised on television. The way acetylcholinesterase inhibitors work is they increase or they prevent the breakdown of a chemical in the brain called acetylcholine. So the way nerves talk to each other is they release a chemical, and the chemical is called a neurotransmitter. And so this nerve here will release, nerve A, will release a neurotransmitter that will go to nerve B in this case, and that's how they talk. There's lots of different types of neurotransmitters: dopamine, serotonin, norepinephrine. In this case, what we're talking about is a neurotransmitter called acetylcholine. And acetylcholine is involved in memory and attention. And so there's an enzyme then that breaks up acetylcholine, and it gets rid of it. You don't want acetylcholine just persisting in the cleft. You don't want, eventually the nerves need to stop talking to each other. And the way they stop talking is that acetylcholine will be metabolized by an enzyme called acetylcholinesterase. Well, there's these drugs, what they do is they prevent the breakdown of this chemical. They prevent the breakdown of acetylcholine. And so if you prevent the breakdown of acetylcholine, then you get more acetylcholine in the cleft, and the nerves, in this case, can communicate more effectively. And so that's how acetylcholinesterase inhibitors work. There's another medication class out there that are called NMDA antagonists. And there's only one medication that's marketed in this class, which would be memantine, which is marketed as Namenda. And so the way on nerve cells have different neurotransmitters. And so in this case, there's a neurotransmitter called the NMDA neurotransmitter. And so it looks like this. And so what ends up going through the neurotransmitter and into the nerve cell when the transmitter is open is calcium. And so if too much calcium enters the nerve cell, then you get free radical damage and the nerve cell dies. And so what memantine does in this case is it blocks this receptor, and it prevents too much calcium from entering the nerve cell. I always really hesitate when I talk about this because what I don't want you to do is get the message that calcium is bad. And so the last thing I would want any patients to do, particularly those with osteoporosis, would be to stop taking calcium. My God, please keep taking your calcium. And so I guarantee you what will worsen your cognition more than this would be if you were to break a hip and end up in the hospital and have to lay in a hospital bed for weeks and weeks and weeks. That will deteriorate your cognition. In this case, what memantine is doing is it's just slowing down the flow of calcium into cells, and thereby it acts in a neuroprotective way. It protects the neurons. And so those are the medications that are approved right now for Alzheimer's disease. There are other medication classes that are being developed, and these other medications look to target the amyloid proteins and the tau proteins that we talked about before, but they're all still in clinical trial phases. And so right now, these are the medications that we have. This, and of course, the behavioral and interventions that we also do with our patients. So that will conclude this talk of what is dementia. Hopefully by now you have a general understanding of the diagnostic criteria for dementia. I hope that you appreciate that there are different dementia types, that it's not all Alzheimer's disease. In fact, there's lots of different pathways for one to become demented. And then just a little bit about the treatment as well. Thank you for your kind attention. Okay, so now we'll open it up. If anybody has any questions, I would love to make up answers, please.
I have one.
Sure. What is your question?
I remember that my dad has been here at Morningside for a year, and I don't know, before he came here, occasionally he would have, I think, what I guess you could call a hallucination. He would mention somebody that he saw, and I don't know if it was anybody that was familiar to him. I think one time it was, but I don't know if since then that's occurred. But my question was just, how long is a hallucination liable to last? I mean, is there a typical amount of time when the person sees this image? Will it be an hour or two, or
Sure.
just a few minutes?
That's a good question, and I don't know if that's. I don't ever remember reading how long it'll last. I know from just kind of clinical experience that they seem to persist a long time, and even when they're told to go away, a lot of times they don't go away. They're kind of always present. People can get hallucinations with other dementia types, so you can get them, for example, with Alzheimer's disease or vascular dementia. You could imagine that if you had a little stroke in the right part of the brain, then that could trigger hallucinations. And so with Lewy body disease, it's important to consider that there are these other criteria as well. It's not just a hallucination. However, the other thing to consider, you mentioned that your father, maybe he doesn't have them anymore, or you haven't heard about them in a while. One thing that we know about Lewy body disease as well, I went over some of the medications that we use to treat Alzheimer's disease, and one of the classes is acetylcholinesterase inhibitors. And so again, these are the medicines like donepezil, rivastigmine, galantamine. And these medicines seem to help people with Lewy body dementia way more than they help people with Alzheimer's disease. And in fact, they can help the hallucinations. And so what I would wonder about your dad is, of course it could be Lewy body dementia, it could be something else, but if he's on an acetylcholinesterase inhibitor, it might be that his hallucinations are being treated through the Aricept, Razodine, or Exelon that he's taking, if perhaps he is taking one of these medications.
He is, yeah.
Okay.
Okay.
Well, thank you so much for your kind attention.